Hello everyone, dear colleagues, friends, ladies and gentlemen. My name is Roxana Moran from the Mount Sinai Hospital here in New York City. I am one of TIO's course co-directors, and on behalf of Nicholas Van Meegen and my fellow faculty, I can't believe we're already at the final day of 2022 edition of Transcatheter Interventions Online. We have a fantastic past 2 days. Amazing. The first day was covered by structural heart with TAVR and mitral and aortic valve diseases, interventions, debates, and wonderful, wonderful lectures. Day 2 was focused on complex coronary interventions, and those also was a great day of great live cases. Our third and final day of TIO will consist of a keynote lecture from the most fabulous, my mentor, my personal mentor, and of course, the fantastic Valentin Fuster, who's going to be followed by exciting debates and discussions. The day will follow with 2 excellent, incredible cases from Leipzig Heart Center and the Erasmus Medical Center. I'll be joined throughout the day by our esteemed lineup of faculty, but today I'm joined with Lars Sundergaard, Nicholas Van Meegen, David Hildick-Smith, and Kendra Grubb this morning. So without further ado, here's what's coming up on TIO. Let's begin day 3. What an honor it is for me today to launch this third day of TIO with our keynote lecturer, Dr. Valentin Fuster, a legend. I mean, he's the physician-in-chief of the Mount Sinai Heart and the entire Mount Sinai Hospital system, health system, but to me, he is a mentor-in-chief, an editor-in-chief, a human-in-chief, and a fantastic cardiology-in-chief of all of us, a legend, truly, what he's done. He doesn't need much of an introduction. He really, truly is amazing. He's the director of the Mount Sinai Heart and the Cardiovascular Institute. He's the Richard Gorlin Professor of Cardiology. He's a past president of the American Heart Association and the World Heart Federation. He's the current editor-in-chief of the JACC journals, the Journal of the American College of Cardiology, all of those journals. And of course, he is a gold medalist for the European Society of Cardiology. And did you all know that he also received the Grand Prix Award of the French Academy of Science? He's the 2022, the most recent one that many don't know, but he's the Prince Medahall Award in Medicine, which is one of the highest honors in medicine that can be given. And this year, at the ACC 2022, in just a week, he'll be awarded Innovation in Science Award. Oh, it's so fantastic to have Dr. Fuster. So let's go to our keynote lecturer who's going to talk to us about development and innovation in cardiovascular health, age-dependent program. His topic is subclinical, listen to this, imagenomics, a new word that he's coined. Let's see Dr. Fuster.
Thank you very much, Roxana, for your kind introduction. It's a pleasure to be here today in New York. And let me just give you a talk for about 25 minutes about what I consider is a new movement in the field of cardiovascular disease. And this is the title, Development and Innovation in Cardiovascular Health, an Age-Dependent Program. And certainly I'm going to be specifically talking about subclinical imagenomics, which is a title that may be new to you, but a lot happened between 2020 and now in 2022. Let me begin by saying that in the bottom of the slide is what we have been doing over the years. And here's a red arrow going up and saying, you know, the disease is already developed. Let's try to do the best we can for the patient. We are now moving into number 2, which is what happened before the clinical manifestations at different ages, between age 60 and 100, between age 20 and 60, and between birth and age 20. Very important. The question is number 3, how are we going to approach this new way to look at things much earlier with new technology? Here you have imaging and genomics, we call imagenomics, artificial intelligence. In blue have the circulating cells, the monocyte, which contains a lot of information about each of us. And in the bottom, which I will be talking today, is the new pharmacology, is really to enhance the defense mechanisms that we are actually trying to find at the time of early ages. So let me begin by saying, what is the challenge between age 20 and age 60? I think you will agree. The challenge is, I am developing the number 1 killer today, which is atherothrombotic disease. How can I know this? Well, this is my task. These are the conventional risk factors that you all know, and I don't have to repeat them, are acquired risk factors. Some are behavioral, some are not, but this is the question. How the risk factors work, and classically is an impact of the risk factor into the endothelium. With normal or abnormal cholesterol, the LDL enters into the vessel wall, and then the disease begins. This is the classical approach. As you will see in a moment, this is more complex than in the way I am defining it. Well, we said, let's go into imaging. Imaging probably, if you see the disease, is probably the main risk factor. But how are we going to do it? Intravascularly? I am interested in global health. I cannot go into 1 of 1,000 people who have a study with intravascular just imaging. I want to go to the global population, and this led us to the development of new technology. This is 3D ultrasound addressing 5 regions, the 2 carotids, the main aorta, the 2 iliofemorals, and then we have CT calcification indirectly to address the coronary arteries. The study began with 4,000 people in Madrid, apparently normal, between age 40 and age 55. Finding number 1 is in the bottom. The femoral region is the first region, then in 75% of people, the disease begins. It's not clinically manifested because the iliofemoral region, these are large arteries. On the other hand, the coronary arteries come next, but they are very small, and that's where the clinical manifestations tend to begin. This is the first finding. Then what we have here is these 4,000 people. The 3 columns on the left are males, the 3 columns on the right are female. Look at the middle column in males. This is under age of 50. What do you see? Pale is one of the 5 of the 6 regions being affected with subclinical disease, and then you have 2 or 3, 4, 5, or 6. So 2/3 of male under age of 50 have already subclinical disease. And on the right, in the middle, women, 50%. What happens is, after age of 50, the disease grows a little bit more rapidly in women than it is on men. And here in the bottom on the right, you have two statements, which are two findings. First, the disease begins with a high incidence earlier in life than what we expected, although autopsy data suggested this. And second, most importantly, that I have not presented, 41% of these people at 4 years of follow-up have already progression of disease. Actually, we are following these 4,000 people for 20 years, and we are addressing imaging and many other aspects every 4 years. Here's the story which is very important. On the right, positron emission tomography of the main arteries. On the left, magnetic resonance imaging. 900 of the 4,000 people were imaged in this way. On the right, in yellow, what you have is actually inflammation with cholesterol deposition. On the left, with MRI, you have fibrotic lesions. And now comes the critical aspect that I want to discuss today, is the bone marrow. The bone marrow actually is called by the deposition of cholesterol in the artery, and macrophages go to the arterial system. And their job is to clean the artery, that is to absorb the cholesterol. So we could say there is a war here between a process of substrate that is a foreign body, cholesterol, and a defense mechanism that is the bone marrow. And you know what? Most of the early lesions end up with magnetic resonance imaging into early fibrosis. So the winner is the macrophage. But look what is next in the right, apoptosis. I'm not going to talk about this now, but just to say, as I will show in a moment, that when there is too much substrate, too much LDL cholesterol, the macrophages come in and they find this is overwhelming, and they say, I cannot do my job, and I commit suicide. This is apoptosis. And during this suicidal, then cytokines and tissue factor are being released, and we are now already at the latest stages of the disease with plaque rupture, thrombus formation, and so forth. But I am still in the early stages, which is actually stage 1, and then you see in the slide, stage 2 is the latest stages of the disease. We will talk in a moment, out of 4 defense mechanisms. Let's proceed. Here you have the bone marrow with positron emission tomography. You see in blue is activated. At the same time, see the artery, the inflammation. This is actually published this week, I think it was yesterday. And this is very fascinating data. We now are seeing how synchronously the bone marrow gets activated with inflammatory process in actually the artery. So this is actually very, very exciting. Now here you have these 900 people, just focus on the right. On the bottom are fibrotic lesions with MRI. And what it says is, more is the number of risk factors, this is in the abscissa, higher is the burden of disease. Fibrotic disease, you see the blue line? Iliofemoral region, is a head. On the top is positron emission tomography, the same thing. We believe that the lesions with positron emission tomography precede the lesions that you see in the bottom, which are fibrotic lesions. Well, we can say point number 1, the disease starts early in life, is silent, the iliofemoral region is the start point, and the risk factors and inflammation are the main protagonists. Let me now move into point number 2. We see many patients without risk factors who develop events. These are the 4,000 people divided by Framingham on the left. The large column is the one with high risk, middle is middle risk, and the other on the left with this circle is low risk. On the right is 3, 4, 5 risk factors, in the middle is 2 or 3, in the left is 1 or no risk factors. Why they have, as you see in color, so much subclinical disease, when in fact there are no risk factors? This is the reality that we found. And now there are 2 answers that are very fascinating. What we see here is the 4,000 people, and the arrow on the middle is normal levels according to guidelines, between 100 and 120 milligrams DL of LDL cholesterol. That's what we are measuring. But you know, not to have subclinical disease, you need to have an LDL of less than 70, which is the arrow on the left. So we found the same thing, and it's in the bottom, with diabetes. Hemoglobin A1C, the pre-diabetic, with 5 to 6, saying, well, this is pre-diabetic, it's just an alarm system. It's not. We have similar data. What we consider normal or close to normal is not. And in the bottom is triglycerides. All of this we published during the last year. So what we can say is that in our society today, what we call normal is quite abnormal. What happened is the guidelines are based on clinical events, are not based on the new technology that is telling us what precedes these events. And this is even more interesting. You know the cardiac study. To me, is the best longitudinal study today in following people between age 18 and 40 until age 75. And they have a long follow-up in terms of cardiovascular events, but we had the opportunity to look at the risk factors in the first 40 years of life, between age 20 and 40, is in yellow. And we were not surprised into the findings. What you see here is LDL. All these people are age 40, the same risk factors, the cardiac study. But what we see is more is the burden of a risk factor between age 20 and 40, higher is the likelihood of events, which is in blue. So what we are really saying to you is that actually what goes on before, even we consider normal, with our data that what we consider abnormal, we see great trouble in the follow-up of these people in the cardiac study. Risk factors were completely ignored between age 20 and age 40, or we consider normal what was not. And this leads to the second concept I want to present today. Not only cardiovascular disease is frequent and subclinically starts at an early age, but about risk factor levels, unfortunately, we have been considered normal what is completely abnormal. And even more, we didn't pay attention to the cumulative effect of the risk factors under the age of 40. So friends, guidelines is nice to talk about it, but they are, to me, going backwards. We have to go much earlier to really understand the events that you face in the cath lab later on in life. This is the second concept. Now comes the issue. And this is new. We are going to do the first randomized study in young people, the pre-CAT study. Between age 20 and 40, those with an LDL cholesterol more than 70 milligrams DL, which for us is abnormal, are going to be randomized on the right with very active treatment, bringing the LDL cholesterol below 70. And on the left, we are going to follow the conventional guidelines. The primary endpoint in green, the progression of disease. The secondary endpoint, events. Why the events are secondary? Because they are very young people. So we can look at the progression of disease, but it's not easy to have events at this young age. But I think we have a way to address the events. And this is actually the bioimage study, and you, Roxana, participated in this study. 6,000 people between age 60 and age 100. And this is very, very interesting. We just got the data a month ago. And that is, depends on the burden of disease at time 0, between age 60 and age 70, you can project what is going to happen in terms of cardiovascular events and mortality 12 years later. So in our pre-CAT study, we'll have a young person, but when the burden of disease is equivalent to the burden of disease that we see at this age, we will begin to project mortality, or actually cardiovascular events, will be a secondary endpoint, because really what we are doing is using two different studies to come up with a prognosis. But I think the question is very clear. We are now going to develop a unique approach of trials beginning in young people. And the first that we are going to do is addressing LDL, what I consider what the abnormal values are. And this is the randomization. And these individuals will be followed for a period of 10 years. Progression of disease, and then see what we can predict in terms of the events for what I presented to you. And now comes the issue. what I do with my people, what I do with my patient, or with this young individual that comes to me. We took two approaches on people who already have disease. One approach is individual approach. This is in the top is a study in Kenya, where there is a lot of hypertension in this area of Kenya because they eat with salt, or they keep the food with salt, I must say. They don't have freezers and they have hypertension. So we approach these people individually, great success in terms of what was achieved, extremely expensive. So when we go individually, it's a very expensive approach if you want to change habits. So in the bottom, we have 3 studies that we did, one in the Caribbean, another in one town in Spain, Cardona, and another in 7 towns in Spain that you see in the map. And we did group therapy. That is 10 to 15 people get together. You are obese, I smoke, you help me, I help you, once a month over a period of 1 year. What happened? Amazing success. All the studies I'm presenting to you are randomized, by the way. Amazing success. But now I'm giving you a summary of all the 5 studies we have done individually and as group therapy on a single slide. And it's fascinating. This is actually one of the studies of group therapy. You see the red line? Fantastic results. Cholesterol, obesity, smoking. You should get the top. At 1 year, look what happened. It goes down again. Not to the bottom, but it goes down. So to have sustainability is very difficult. But look at the blue line. You know who they are? The control people. Why they do so well? Because are in the same culture. So what we are learning now is the importance of the environment can make even people who are not intervened to behave reasonably well. The issue of culture. So this is what we learn, and this is actually the bottom of the slide in green, and that is the modification that we can do with addressing health in people that have disease already seen by imaging is transient. So we as adults need re-education. And this is a reality, so be sure that we understand that sustainability is probably one of the most important challenges that we have today. But let me tell you further. What you have here is genetics. I didn't talk about genetics. What is most important, genetics or the acquired disease with the risk factors that I mentioned before following Framingham? What we did is we joined the ARIC study, the Malmö study in Sweden, and the health study in women in Boston. And here on the left, you have a risk factor profile on genetics. You see, higher is the risk factor profile means more mutations out of 50 genes that were identified from the literature. And then you have in the bottom on the left is the blue, no mutations. And you can see there is a progression of disease or events related to the genetic type of stratification. But the same on the right with the 7 risk factors. We said high risk, as we mentioned before, middle or low risk. And now come the 3 findings. First, surprisingly, both were independent, the genetics and the risk factors, except for diabetes type 1 and familial hypercholesterolemia. Second, most of the people with genetic stratification have risk factors. In this country, 98% of people have actually at least 1 risk factor of the 7. So you may have a high genetic trait, but you cannot say, I'm not going to do anything with my life, because you still can do what we did in the study. In those with high cholesterol, we use statins aggressively, and the events and progression decreased by 50%. This is published in the New England Journal of Medicine in a subsequent study. And then the third issue, quite fascinating. Gene mutation, CHIP, what we are talking about. You know, the hematologists know this very well, clonal hematopoiesis of indeterminate potential. It's called CHIP. What basically happens, these cells that defend us from the substrate can be genetically altered by some mutations of the genes I mentioned. A very interesting one is actually TET2. You will recognize this. on the right are macrophages that are profibrotic after they do a good job in the early stages of the disease. In the left is when there is trouble in the artery, clots, a lot of plaque, debris, and so forth. Macrophages type 1 come in. You know who calls them? Interleukin-1. That's the reason why Cantos work, is because the caller was neutralized with the monoclonal antibody. But let me tell you what TET2 is. TET2 is doing, in a way, preventing this cleaning of the artery to be too aggressive, because that's what tends to happen when interleukin-1 is not neutralized. New events come in. When TET2 is mutated, it's bad news. Now we are understanding a little bit the genetics of the disease. And I go back to the same slide I presented before. I said there are 4 defense mechanisms. The first one, fibrotic phenomena, no much substrate. The second one is here, late apoptosis, too much substrate, no sustainability. The risk factors continue, cytokines, tissue factor, plaque rupture. But here's the third, cheap. Maybe the problem is not that there is too much substrate, it's the motor engine is not working. And that's where the genetics are actually coming in. And this is quite fascinating, because here we have 3 defense mechanisms, the fibrotic phenomena, the apoptosis, and CHIP that particularly works in the older people, the risk factors. But it's something quite unexpected. The risk factors, hypertension, diabetes, the issue of obesity, the metabolic syndrome, do you see what is in red? The bone marrow is activated. So we now believe that teleologically, when the risk factors do damage, entering cholesterol into the artery, at the same time, they are for rescue, asking the bone marrow to react. And this, to me, is absolutely fascinating, because it's a 4th mechanism, a mechanism of exhaustion, is the risk factors are calling for help. And this is actually the 5th concept I wanted to present to you today, and that is the second stage apoptotic macrophages when there is too much substrate. Later on, the gene mutations, the motor engine is not working, and still we have the bone marrow as a secondary phenomena to the risk factors. So I'm not going to get into the details, because I promised I would be 25 minutes. I have 1 minute left. I was going to talk about the elderly. Next time you invite me, because we are looking at the same thing in the brain, and it's fascinating. But let me finish. This is the summary of what I said. Early in life, in the left, you begin to work. Higher is the benefit, lower is the risk. When you go towards the right, higher is the risk, lower is the benefit. And that's really, this is really what I try to present to you today. I could go into the brain with cognitive function. I could go into the projects we have in children. We are working with 50,000 children around the world. But with 25 minutes, I cannot go much further. And just to say, I had 10 concepts today. I only mentioned 5. The other 5 were in the brain. But I feel very strong about succinctly beat on time. There is a movement, and the movement is the development of technologies, very sophisticated technologies that go earlier in life. And remember, 3 ages are quite different. The challenge at this age, 20 to 60, do I have disease? 60 to 100 is my brain, cognitive function. Age from birth to age 20, education. These, to me, are the 3 challenges that we are working on, and I appreciate very much that at least you gave me the opportunity to talk about one of the challenges we teach between age 20 and age 60. Thank you very much for your attention.
Wow, Dr. Fuster, what an incredible talk. And I'm floored by the fact that we all need to start early, right? And I mean, I'm certain, Nicholas, maybe you want to say a couple of words to Dr. Fuster before he leaves us, but What an incredible honor. And I guess he just promised he'll be back next year. Is that right?
If you invite me.
Well, Roxana, well, you can expect an invitation because I'm blown away. This was absolutely amazing. We're only talking about interventions and new techniques, but this is from a different level. This is where it all starts, and I think primary prevention is really the key, and it has been inspiring this 25 minutes, and I feel sorry that we only allowed you for 25 or 30 minutes. I wanted to have you an hour if I can keep on listening. But maybe I do have a small question for you. So you were mentioning also the mechanism of exhaustion. But does that mean that you can also stop this mechanism of exhaustion and then save person lives? Or is this inevitable, this mechanism of exhaustion?
Thank you very much. You know, now that we are learning about the molecular mechanisms by which the artery calls to the bone marrow, and interleukin-1 is critical, and the genes that I mentioned are critical, maybe we will be able in the future to address what I said at the beginning in my presentation, is to enhance the defense mechanisms. And this is, to me, is a challenge from the pharmacological point of view. Look what happened in heart failure. If you look at the recent pharmacological approaches, all enhance defense mechanisms. If you go to the vaccine, the mRNA, you know, the mRNA we thought was a marker of disease, when in fact we found is a defense mechanism against disease. Now the vaccines came in. So what is happening, and I'm presenting to you this from the imaging and genetic point of view, we are moving to a new era that is to understand what are the defense mechanisms in health. And this probably will answer your question, and that is, can we avoid this end phenomena and just keep the defense the way it should be? That's, to me, is going to be a tremendous challenge for the future, pharmacologically speaking. Cantos, to me, was the first that gave us a feeling of this defense mechanism affecting the artery.
Well, thank you so much, Dr. Fuster. What an honor to have you, and we really can't wait to have you in TIO 2023. Thank you, Dr. Fuster.
Thank you. Thank you.
Now, I'd like to now go to the beginning of the day, and let's take off with the day with our wonderful speaker that's coming up, which is Nicholas Van Meegen, who joins us from Erasmus. Nicholas is presenting on the role of NOAC in TAVI 2022.
Well, Roxana, this is a humbling experience to have to give a lecture after a keynote by Dr. Fuster. I mean, he is such a role model superstar. I remember 20 years ago when my dad took me, when I was still in my early cardiology training, my dad took me to the Fuster meeting in New York in December, and I was blown away by this man. And we're now 20 years later, and I'm still blown away. So he's a special man, and I hope we can invite him back one day in one of the next TIO meetings. But I'm going to talk now about the role of non-vitamin K oral anticoagulant drugs in the context of transcatheter aortic valve implantation. And we have seen a number of randomized controlled trials that also were published in the New England Journal that can add fuel to the discussion. But we have to acknowledge that there are quite some gaps in the current guidelines, and the contemporary guidelines have recently been updated. On the left-hand side, the United States, on the right-hand side, the European guidelines. And basically what in the United States was obvious in their guidelines was that indeed you can use a NOAC as an alternative to a vitamin K antagonist in patients with valvular disease or in patients who have had a bioprosthesis at least 3 months ago. But within 3 months, the guidelines, the US guidelines, still recommend to prescribe vitamin K antagonists and not the non-vitamin K antagonists. It's a little bit different in the European guidelines, where also they say, well, you can consider to use a NOAC and even prefer a NOAC over a vitamin K antagonist at least 3 months after the bioprosthesis has been implanted. And only in the context of a mitral valve bioprosthesis, you could also consider to use a NOAC instead of a vitamin K antagonist within 3 months after the mitral valve surgery. And that obviously has to do with the RIVER trial that was published in the New England Journal, which was a small trial. But both guideline committees basically acknowledged that their recommendations were predominantly based on the registry data, and that more data was desperately needed. Well, funny enough, at the time that the European guidelines were presented, at the same day, Dr. Dangus also presented the envisaged TAVI-AF study results, and we'll get to that in a second. I think an important randomized controlled trial that really helped shape up new recommendations is the popular TAVI Cohort B trial, also the Cohort A, but let's focus on Cohort B because that is on patients who have an indication for oral anticoagulant drug therapy. It was a small trial, only enrolling 313 patients, and they were randomized to oral anticoagulant drugs because they had an indication for that, and then randomized the patients to either additional clopidogrel or no antiplatelet drug therapy. And what you can see on the left-hand side is that the combination, the adding of clopidogrel to oral anticoagulant drugs, and only in 15% of those patients there was a NOAC being used, you could see that there is an increase in major bleedings. There was also an increase in the composite endpoint of cardiovascular death, non-procedure-related bleeding, stroke, or MI. So that basically was a strong argument in favor of not adding antiplatelet drug therapy on top of any kind of oral anticoagulant drug in patients who have an indication for oral anticoagulant drug therapy after a transcatheter aortic valve implantation. So I think that set the stage. We already know that also in patients who have no indication for oral anticoagulant drugs but get aspirin after a TAVI procedure, it also no longer makes sense to add clopidogrel to their therapy. So I think it was the end of clopidogrel. As I mentioned, the envisaged TAVI-AF trial was presented last year at the ESC meeting by my good friend George Dangus, and this trial was from a different level. It was much larger than the popular Cohort B trial because it enrolled more than 1,400 patients. Patients were randomized after a successful TAVI procedure to either edoxaban or a vitamin K antagonist. The issue was that during the time of study enrollment, it was still common practice to add antiplatelet drug therapy on top of the oral anticoagulant drugs. So you have to take that into account when you try to interpret the data. Mean age of the patients was 82 years old, the STS score was 4.8, and approximately 50% of the study population were women. In terms of the primary outcome, the net adverse clinical event rate was similar between the two treatment strategies, and this is a composite of thromboembolic events and major bleedings, but there was also an excess of major bleeding, and the major bleeding was in was a co-primary endpoint. It was a safety endpoint. And that was a little bit of, that was unexpected, because obviously we are all aware of the landmark randomized controlled trials on the use of NOACs in patients with non-valvular atrial fibrillation. And there you basically saw the opposite. You could see, or there was no clinical difference in outcome and clinical thromboembolic events between a NOAC or a vitamin K, but at least the NOACs seem to have a better safety profile with less bleeding. So why don't we see that in the envisaged TAVI-AF trial? Well, I think because we're talking about a different population. These are not patients of 60 to 70 years old, who were the patients from the landmark AF trials. We are now talking about patients of at least 80 years old. Mean age in envisage was 82 years old. So there was also a lower prevalence of heart failure in the landmark non-valvular AF trials, whereas obviously in the TAVI trial, in the envisaged TAVI-AF, 80% of the patients had heart failure. Bioprosthetic valves were not used in the landmark trials like the ENGAGE-AF. And also we have to realize that patients with aortic stenosis by default have a higher risk of gastrointestinal bleeding, because there is a correlation between arteriovenous malformations, GI arteriovenous malformations and aortic stenosis. And there is also this issue of acquired von Willebrand's disease associated with aortic stenosis. And we have to acknowledge, if you replace the valve, then these issues may change, but they may not resolve completely, so the patients may be at increased risk for GI bleedings. And basically that is what we saw in the envisaged TAVI-AF trial. There were major bleedings, and the major bleedings were predominantly driven by more GI bleedings. If we were looking at life-threatening bleedings or fatal bleedings, there was no difference between the two treatment arms, between edoxaban and vitamin K. And also there was no difference in intracranial hemorrhage between the two treatment arms. As a matter of fact, numerically, there were fewer intracranial bleedings in patients on edoxaban after a TAVI than with vitamin K antagonists. I mentioned the issue of concomitant antiplatelet drugs. We know from the first trial that I mentioned, the popular TAVI trial, that there is no point in adding antiplatelets to oral anticoagulant drugs after a TAVI procedure, but still, while we were enrolling patients in envisaged TAVI-AF, almost 50% of the patients were pre-specified as requiring antiplatelet drugs on top of the anticoagulant drug regimen. And that obviously is not anymore our practice. As a matter of fact, 60%, eventually 60% of all patients at one point during the study were combining their oral anticoagulant drug therapy with aspirin or clopidogrel. So basically that is an important finding that we need to consider when we want to interpret the data. And then finally, the edoxaban dosing schedule was the classical dosing schedule as it is mentioned in the IFU, but obviously the IFU probably was determined on a younger patient population. And this is what I'm talking about. On the right-hand side, you see whether or not the patients had a dose adjustment. And if there was a dose adjustment, so patients were no longer taking 60 milligrams but 30 milligrams of edoxaban, then there was no longer a difference in major bleeding between the two treatment arms, and there was also no difference in major GI bleedings anymore. Similarly, if you look at the patients and compare the patients who were on concomitant antiplatelets or no antiplatelet drugs, again, patients who did not get concomitant antiplatelet drug therapy had no difference in major bleeding between the edoxaban arm and the vitamin K arm. So I think these are important findings and insights that in patients, in elderly patients who require edoxaban therapy, we really have to avoid concomitant antiplatelet drug therapy, and also we have to be very conscious about dose reduction. So this impact of dosing was not so unexpected, because we also have this sub-analysis of the ENGAGE-AF TIMI-48 trial, which was the landmark trial of edoxaban in patients with non-valvular atrial fibrillation. population. And on the left-hand side, you see that the low dose as compared to the high dose, the 30 milligrams as compared to the 60 milligrams, there was no difference in the net adverse clinical event rate. And on the right-hand side, it became clear that patients who were taking a low dose indeed had less major bleeding. So there was already an indication there that this lower dosing might be beneficial, at least in a subset of patients, because overall in the ENGAGE-AF-TIMI trial, on the right-hand side, it becomes clear that the number of strokes or systemic embolic events were higher in the patients with, who were taking the low dose of edoxaban. So I think that was also the reasoning why it's 60 milligrams that basically is in the IFU and not 30 milligrams, but the reality might be different in octogenarians, who are obviously very different from septuagenarians. So then subclinical leaflet thrombosis, if we really focus then on TAVI patients, subclinical leaflet thrombosis is an important finding by CT scanning. And there was a lot of fuss 5 years ago about this finding. Was it clinically relevant and what would be the impact down the stretch? And there has been published a recent meta-analysis in JACC Cardiovascular Interventions where they pooled more than 11,000 patients from 25 studies. Turns out that the main risk factors for subclinical leaflet thrombosis was the use for an intra-annular functioning valve. So not the evolute or the core valve or the accurate, but more a portico or a navitor or a sapien valve. And also the use of antiplatelets was also associated with more subclinical leaflet thrombosis than oral anticoagulant drug therapy. If you and overall, the incidence was 6% in the overall population of patients who were on oral anticoagulants or antiplatelets or the combination. If untreated, the presence of the subclinical leaflet thrombosis seemed to be associated with a slightly increased risk of stroke, neurological events. This was never documented in these studies by themselves, but in this pooled analysis, there definitely is a signal towards more neurological events in the context of subclinical leaflet thrombosis. And what can you do about it? Well, oral anticoagulant drugs can solve the issue. Here in this slide, there was also this analysis where they looked in that same meta-analysis whether there's a difference if you were on single or dual antiplatelet drug therapy. Well, no, it doesn't make a difference. And is there a difference between antiplatelets or oral anticoagulant drugs? Yes, there is. If a patient is taking oral anticoagulant drugs, the incidence of subclinical leaflet thrombosis is in the single digits. It's then below 5%. So does that mean that we have to treat everybody with oral anticoagulant drugs? Well, that remains the question, but this is not a trivial finding. As you can see from the low-risk trials, the randomized low-risk clinical trials, randomizing patients to either TAVI or surgery, subclinical leaflet thrombosis was quite common, not only in the TAVI arm, but also after surgery. At 30 days in the PARTNER 3 trial, 13% in the TAVI arm, 5% in the evolute low risk. It was around 16% for both treatment strategies. And at 1 year, there was no difference in subclinical leaflet thrombosis between surgical or transcatheter aortic valve replacement. Also of interest in both studies, when patients were not switched to an oral anticoagulant drug therapy, then there was a spontaneous resolution in approximately 50% of the patients with subclinical leaflet thrombosis, whereas subclinical leaflet thrombosis appeared in 1 in 4 of the cases between 30 days and 1 year. So it's a very unpredictable process, the subclinical leaflet thrombosis. And if you ask me, I'm still not convinced that it is clinically relevant. But there has been already a trial that focused and zoomed in on the issue of subclinical leaflet thrombosis, and this is the Galileo trial. The Galileo trial evaluated, explored whether NOACs, a non-vitamin K oral anticoagulant drug, rivaroxaban, would be better than antiplatelet drug therapy in patients who had no indication for oral anticoagulant drugs for atrial fibrillation or whatever after a TAVI procedure. And the issue in this study was, again, that there was also concomitant antiplatelet drug therapy involved for at least 3 months. So basically the study was comparing rivaroxaban a low-dose rivaroxaban with aspirin for 3 months versus aspirin with clopidogrel for 3 months. Interestingly, the incidence of reduced leaflet motion, subclinical leaflet thrombosis, was higher with antiplatelets versus the rivaroxaban group, and also leaflet thickening was quite common. It occurred in a third of the patients in the antiplatelet cohort and in 10% in the rivaroxaban cohort. But obviously, the Galileo trial, the main trial, was a negative trial, and that is why we should not implement NOACs as an alternative for antiplatelet therapy after a TAVI, because the rivaroxaban cohort was exposed to a higher primary efficacy endpoint. So there were more thromboembolic events, and there were also more bleedings with rivaroxaban as compared to antiplatelet drug therapy. So I think this consensus document that was published in 2022 in the European Heart Journal makes total sense and really summarizes what we're talking about. On the left-hand side, you see the patients who have an indication for oral anticoagulant drugs after a TAVI procedure, so for instance atrial fibrillation. Well, if they did not have any recent PCI, then basically it's monotherapy of an OAC, either a vitamin K antagonist or a NOAC. And if the patient did have concomitant PCI or a recent PCI, you can combine it with clopidogrel for 3 months, but that's it. No triple therapy, and really after three months, out to 6 months maximum, you would proceed with a monotherapy of oral anticoagulant drug therapy. So in conclusion, NOAC seem a good alternative to vitamin K antagonist in patients with atrial fibrillation, but we need to respect the dose adjustment criteria. We should not overdose our patients, especially not the octogenarians, and we need to avoid concomitant oral antiplatelet therapy on top of the NOAC. The question is, do we need new trials? Do we need new trials, for instance, on the lower dose edoxaban rather than the high dose of edoxaban in octogenarians after TAVI? Should we duplicate the envisaged TAVI AF in octogenarians, but then using the 30 milligrams and not the 60 milligram edoxaban dose? And do we also need specific trials in patients with aortic stenosis and atrial fibrillation and concomitant coronary artery disease? What kind of antithrombotic regimen would be the best? And finally, do we need more trials to try to expand the indications for a NOAC beyond atrial fibrillation in TAVI? With that, I give the word back to you, Roxana.
Wow, fantastic. 2 amazing lectures, but thank you for that lecture on NOACs. In TAVI. So I'm going to go to you first, Kendra, and then we'll ask Lars. Is there a role for NOACs in TAVI? And if so, who are you using it in?
Well, I think that this is a challenging situation. So we're using NOACs in patients that have an indication, as Nicholas mentioned, as well as our valve-in-valves. But in terms of a patient that just has a native TAVR, we're not using NOACs. We are just using single antiplatelets therapy.
Lars, how about you?
Slides weg.
Of course, patient who got atrial fibrillation or other indications should have NOAC. But patient without pre-existing indication for oral anticoagulation, it's difficult to answer that question. We know there's an increased risk of stroke within the first couple of weeks after, and these patients may potentially benefit from NOAC. I also think we're very simple the way we look at it. So we try to have the same recommendation, whether it's a patient at a high age with a lot of comorbidity or younger patients with no comorbidity. And the risk profile may be very different in these two patients. So I think down the line, we need to tailor the therapy to each individual patient. And just one comment about the NOAC or the anticoagulation in the guidelines. It mostly comes from the surgical literature, and we have no good data in the surgical, but there's some registry showing that if the patient is on vitamin K for the first 3 months after a bioprosthetic aortic valve, the incidence of stroke and actually also bleeding is lower. But again, remember, quite a few of the patients who's undergoing a surgical aortic valve replacement will have new onset atrial fibrillation after the procedure, which is not the case in after TIO procedure. So it's two very different procedures, and it's maybe not the bioprosthetic valve which is causing these events. It's more the procedure, the nature of the procedure itself.
Yeah, no, those are really great comments. And, you know, when you talk about, I mean, I've seen in our own experience, we've used novel oral anticoagulants when we see halt, actually, in patients who don't have any indication. So, David, what is halt? Do you even believe in it?
No, I think we believe in it, but I think we just don't know what it really means and what the implications are in the longer term. Because, of course, you see relatively few patients who actually have valve failure early on, and yet a large number of patients actually have halt. So are efforts to get rid of halt warranted, or might you be doing more harm than good? And I think it's really tricky. You know, the area is very confused at the moment. We have studies on the one hand showing that the event rate is higher if you give oral anticoagulation of a sort of standard dose to patients who aren't in atrial fibrillation. And I think, as Nicholas was alluding, probably the thing we need to do now is refine those trials, and instead of having the patients who have dual antiplatelet therapy, which is of course no longer considered necessary in the absence of stenting, you could have a study of perhaps a reduced dose rivaroxaban or edoxaban, like 10 milligrams of rivaroxaban or 30 milligrams of edoxaban versus just the aspirin. Because I think, you know, we have to separate and distinguish between what is purely an imaging event and what is a clinical event. Of course, it is slightly worrying to know that the stroke rate is measurably higher on meta-analysis with halt. So we can't ignore it, but it is quite confusing to know exactly what we should be doing about it. And we are definitely going to need some more trials with lower dose NOACs.
So just one comment.
Yeah, I mean, I think, yeah, go ahead, Lars.
Yeah, because, you know, Nicholas and I just showed this meta-analysis indicating there's a high risk of TIA or stroke in patients with halt. But just remember two things. It's been shown nicely in several studies. This is a dynamic phenomenon. It's going to change over time, so it can resolve, it can appear again. And the studies was referring to patients who had a high rate of stroke. That CT scan was not done at the same time as a clinical event. So no one actually knows what was the status of those leaflets at the time where the patient had his stroke or the TIA. And also there's quite a few studies trying to compare patients after TIO with the background population, matching for age and comorbidity. And it's showing that when you pass 3 months, these patients have the same risk of stroke or TIA as the general population. So just before everyone is tempted to go home and look for halt or halt and put this patient on oral anticoagulation, just remember that the data is really, really weak, that there is a correlation to these events, and you're going to harm your patient to put them on oral anticoagulation. So be careful about this.
Oh. Mm-hmm. No, I think what you make some amazing points, and I think that as a clinical trialist, I'm most frustrated. I'm also imagine that it would be very important for us to design these studies. We've learned a lot from the trials we've run already. Nicholas, you mentioned lower dose, less is more. Maybe we have to rethink. Maybe we all need to get together to figure out how to do this well going forward, because we really have very little data. And I don't think we can give any kind of a guideline directed therapy to all patients, and we have to think about them individually. Any last points, Nicholas, before we go to the live cases?
No, so I think that the last word hasn't been said on this topic, and I think David also mentioned clearly that we don't know the impact, and at the same time Lars alluded to, we don't know what's happening with this subclinical leaflet thrombosis, because in 50% of the cases it will resolve. And then we cannot be blind for the Galileo results, where the NOAC arm was associated with more events, more hard clinical endpoints than antiplatelet drugs. So let's let that be clear. We cannot advise a non-vitamin K antagonist as an alternative to antiplatelet therapy in patients after a TAVI.
Well, thank you so much. This has been a fantastic session. We had a keynote lecture by Dr. Valentin Fuster, and then followed by another keynote, I think, on NOACs and where their place is in TAVR. Thank you so much. And we're now going to be going over to our live cases. We have 2 concurrent live cases. We have Philippe Lurs and Christian Bessler from the Leipzig Heart Center. They're going to perform a TR case. And then we're going to cut to Erasmus, where Joost Damon and Wijen Den Dekker from Erasmus will perform a renal denervation case. Wow. Let's head over to Leipzig.